afternoon, everyone, and welcome to our third Policy Power Lunch, sponsored by the Policy Impact Project, featuring Greg Robinson from the Autistic Self Advocacy Network. So I'm going to give a brief couple moments on our Policy Impact Project. So our Policy Impact Project team is directed by myself, Caitlin Coffer-Miller, and Anne Rue, and we have Kyle Shavasta here, as well as our project coordinator. And the Policy Impact Project is a venture between the Life Courts Outcomes Research Program area and the Policy and Analytics Center here at PAC at the A.J. Drexel Autism Institute, which are both under direction of Dr. Lindsay Shea. Kyle, would you mind moving forward one slide for me? Thank you. So the mission of the Policy Impact Project is to use research findings to propel systems level policy changes that impact the lives of autistic people, as well as those with other developmental disabilities and their families, by translating research into policy. And the reason we started the Policy Impact Project is there's a large disconnecting gap between research and policy. And there's a need to translate research into research for policymakers and for policy implications to be a part of our research activities. And we focus on autism because it has some specific policy challenges, and there are also broader policy changes that we need to address to best impact autistic people and their families. Now I'm going to turn the mic over to Kyle Shavasta to go over some house rules.
Wonderful, thank you. I get the fun part of telling everyone what to do now. So just real quick, I think a number of us are familiar with Zoom and its various controls at this point, but just real quick, to ask a question to the panelists, please utilize the Q&A box. The icon is below. The Q&A box will, the question and answer session will be facilitated after the presentation. If you are experiencing any technical difficulties, please place your concerns or questions in the chat box. And the chat box, those messages will only go to Caitlin, Anne, and myself. So we'll be able to field any concerns or problems on our end. If you are interested in closed caption, we have a live transcription available. So just hit the CC icon below at the bottom of your screen. With the speaker's consent, we will be recording today's presentation, and it will be available for view later on. And at the end of today's presentation, there will be a pop-up screen with a link to take a brief survey. So please take that and let us know how we are doing. And with that, I would like to hand it over to Greg Robinson. Greg?
Hello, I think I will need, if you can share the screen. Hi, my name is Greg Robinson. I am the Deputy Director of Public Policy for the Autistic Self Advocacy Network. I am here today to talk about a project that we did at the Autistic Self Advocacy Network around making a accessible toolkit for an accessible resource toolkit around to address racial disparities in community living. A little background on myself. I'm, as I mentioned, I'm the Deputy Director of Public Policy for the Autistic Self Advocacy Network. My background prior to ASAN actually is local to you all. I got my master's in public health at the University of Pennsylvania and did some work at the Steinbright Center for career services as a grad student, followed by work in community development in Kensington. So kind of feels like being home here. As far as the Autistic Self Advocacy Network, the Autistic Self Advocacy Network is a nonprofit organization run by and for autistic adults. It is a national grassroots disability advocacy organization for the autistic community that fights for disability rights, as well as full participation of autistic people and involvement in policymaking and ensuring that our needs, that the policy that we see that is generated reflects our needs and respects our autonomy. We support all forms of self-advocacy to change and changing the way people think about autism. So, so I'm here today to talk about racial disparities that exist in community living for people with disabilities. The origin of this project was that racial inequity does impact all areas of community living. A few examples are the legacy of racism in housing and community investment, which shapes the location, availability, and accessibility of affordable housing. The intersecting impacts of bias in education, policing, employment, housing, and healthcare, all of which impact the availability of those services to people who need those services to live in the community. This also impacts the availability of HCBS, which varies, and long-term supports, which impacts access to services, whether people are able to get them in their community or are required to get it either informally or through institutional settings, which can create additional racial disparities. The HCBS workforce is another place where these disparities are present. The support workforce is predominantly women, predominantly people of color, and the weak pay and protections there both impact support workers and the quality of support work that's available, the stability of support workers, which both impacts the care recipients, but also a lot of support workers are supporting, also providing unpaid support for family members or community members, and the low pay and weak support impacts those individuals as well. And then despite these known disparities in services and utilization, there's also very poor data, the less than comprehensive, especially when looking at non-elderly populations and other underserved populations and other communities that are disproportionately people of color. So given that background, we sought to develop accessible advocacy toolkits aimed at identifying racial disparities in community living and proposing ways to advocate to address them. So the goal here was to use the most accessible language we could to highlight how racial disparities were present within major domains of community living, provide specific policies that are contributing to those disparities, and to communicate policy approaches that could address the sources of those disparities. Why did we want to create accessible resources? So there's a few reasons. Accessible resources are frankly better for everybody. They are typically the clearest way to communicate information. And in particular, when we're talking about cognitive accessibility, the average American is frequently cited statistic reads at about a 7th to 8th grade reading level. And as far as comfortable reading level, it's a little below that, around 6th grade. So even for neurotypical audiences, people without intellectual or developmental disabilities, accessible plain language is usually the best way to communicate for general audiences, and the best way to ensure that your communication is received and processed and understood. It also does obviously have a benefit for people with disabilities, as well as English language learners. It's also inclusive. One thing that I frequently highlight in other contexts is that it aids translation into other languages. The simpler the language used, the easier it is to translate it. So that it also can make it even more inclusive than just people who may have cognitive accessibility needs. And then finally, and most importantly, I think when we're talking about civic engagement, engaging policy, accessibility is a civil right. And honestly, civic engagement is a civil right. And it's especially important in this context, that people are able to be informed, able to engage in the political process and advocate for policies that serve them. So as far as accessible resources, there's a few guiding principles. The first one is using simple words. There is a website called Upgoer 5. It's based on a webcomic by Randall Munro called XKCD, where he explained how the Saturn V rocket works using the 1,000 most commonly used words in the English language. So that is not exactly what we're aiming for sometimes, because sometimes you have to use specialized words, but it is a good example of how it is possible to communicate even very complex ideas using very simple language. And so the example here, these words tell a story that using only the 1,000 words people use most often. Even though the words aren't hard, you can talk about hard ideas. Easy words help you talk about hard ideas and let more people understand. So that's an example of that, and you can navigate to this website and try it out for yourself there. It is a kind of fun exercise. But the other important piece, though, is also reducing idea density. So the idea is you want to have one idea per sentence communicated. And as part of that, one thing that you really want to avoid is you are doing a translation, and like other translations, if you're starting with a complex language, you don't want to cut information out. You want to make sure you're conveying as much information, but you are taking complex information and conveying it in a simple manner. So what that may mean is you have to back up and define certain things that you might otherwise take for granted. For example, if you're talking about Medicaid, you want to actually you may want to start out by explaining what health insurance is, the different types of health insurance, and how it's paid for. And then based on that, explaining Medicaid in that context and then going on. So it sometimes means conveying more information, not less. So typically at ASAN, we aim for a 3rd to 6th grade reading level, depending on the topic, the complexity of the subject matter, and the format. This toolkit was about 5th grade reading level. There are other resources where we aim for more like closer to 4. Other things that affect reading level are how long the sentences are, how many syllables per sentence, how many words per sentence, and how long the words are, how complex the words are, and how common they are. Now, those aren't the only things. You also have to look at how direct the language is, and you also want to look at how the flow of information works. But those are kind of the main and most important aspects of using accessible language. And it's something I encourage anybody doing policy communication, health communication to practice, because it is really important to explain often complex ideas for general audiences, to use a lot of these methods to ensure that the people you're attempting to reach, the people who really need that information, are able to understand it. So as far as the content of the toolkit, we zeroed down on 6 different domains of community living, those being emergency response, employment, the criminal legal system, housing, healthcare, and long-term support services, and in particular HCBS. As we were developing it, we recruited reviewers with subject matter expertise in both community living issues and the impacts of racial inequality on disabled communities. Those reviewers provided feedback at each step of the process, both during the research process as well as the drafts, and then finally the first draft of the plain language version of the document. And that part was particularly important. We wanted to make sure that we retained all the information that was conveyed in the previous one. So we really asked our reviewers to focus on that part to make sure the information was retained. And then following that, we also had a review process by via focus group with individuals with intellectual and developmental disabilities to ensure that it was accessible, comprehensible, that it was understandable, and that it provided that it was driving the dialogue, the sort of dialogue we were aiming for. So at that point, if there were anything that people didn't understand, we also made revisions there. So the toolkit itself is available on our website. I think we can link that in chat. The main takeaway for me, as I wrote this, is that racial disparities in community living is an enormous topic. This is something, all of those domains that I listed before are deeply intertwined, and racial disparities are present throughout. And explaining that in a single accessible length toolkit is really hard, which meant that what we ended up having to do was break each topic into essentially its own toolkit. Each domain basically is still about as long as I would ever really want for something that is actually truly accessible. But as a result, each section was written to be used independently. We encourage people to select the domain that they're interested in reading and engage with it on a piecemeal basis. And we provide discussion guides that provides a similar framework for each of those topics. But the general structure we used for each of the toolkits was how are racial disparities present in that domain? What specific policies or practices have contributed to those disparities, and what policy recommendations we had for addressing those as the second section. So I can go briefly through the content of those toolkits. For emergency management, we started by defining emergencies, explaining what we meant by emergencies in this context, which are larger scale, what colloquially we call disasters, as well as explaining how policy shapes where people live, which has a huge impact on how people are impacted by emergencies. And then from there, we talked about how environmental emergencies are relevant to this, and how environmental justice and environmental disparities impact how resilient different communities are to certain emergencies, as well as post-emergency impacts. So then we talked about how emergencies interrupt services that people may need, and how those service interruptions drive greater risk of institutionalization or reinstitutionalization during emergencies. And then finally, we talk about accessibility of emergency resources, and in there we focus not only on disability accessibility, but also language accessibility and the risk that some people face during emergencies of being, especially people who are from immigrant or mixed status families, of being incarcerated or removed. As well as, this was very timely when I was writing it, we also talked about language accessibility around COVID and COVID communications and the public health emergency, and the fact that the deaf community was excluded from some COVID communications that were coming out nationally. So as far as policy recommendations, one big one was we encouraged designating people with disabilities and environmental justice population in light of the fact that people with disabilities are disproportionately impacted by environmental emergencies, as well as the fact that in researching this, we found that while we don't usually think of disability as a geographic issue, the housing policies often does create a geography of disability, and that does overlap with other communities that are at risk of environmental harm. So in addition, we talk about using Medicaid, encouraging the use of Medicaid across state lines when people have to relocate in order to prevent institutionalization or loss of services, and ensuring that benefits allow people to save enough that they can relocate or prepare for emergencies. That's a refrain throughout this, is that ensuring that people can save enough to protect themselves is critical. We talk about emergency service accessibility, both ensuring that people are able to engage with emergency services and evacuation services, but also that the language accessibility exists for emergency communication. For employment, we talk about the state of racial and disability inequities in employment, and the fact that people who are multiply marginalized, who are disabled people of color, experience both of those impacts. We talk about how the benefit structure, again, has a poverty trapping effect, which makes it harder to start to work or work to the extent that you would want if you risk losing benefits when you do. So we do talk about that. We talk about the impact of other disparities like education and policing on employment outcomes, as well as one issue that we focus on in particular is racial disparities in vocational rehab. We did find that both service utilization, there's a significant disparity between people of color and white individuals, as well as on the outcome side for Black and Hispanic people in particular. There is a the employment outcomes are from vocational rehab are typically not as good. And likewise, we talk about racial hiring discrimination and the forms that it takes around race and disability. So our suggestions there were policies that smooth off the benefits cliff so that people can begin to work without risking loss of benefits and supports that they may rely on, particularly given that sometimes people need those supports to continue to work. We talk about ways to increase education equity, both with funding and civil rights enforcement. One takeaway is, again, because of the role of community disinvestment, some disparities in disability support and education are a product of underfunding, and in those cases, funding needs to be the focus. But in other cases, it is bias-driven or driven by other things. In those cases, enforcement is also important. So those really have to occur hand in hand. We talk about addressing inequities in employment supports. Again, vocational rehab stands out there. A lot of people of color who received vocational rehab didn't feel that it met their needs, and that tracks with the sort of the disparity in the outcomes that we're seeing there. And then addressing job discrimination. We talk about a few different things there, including algorithmic discrimination, as well as ways that means by which there could be better enforcement of hiring discrimination. So for support services, we talk about, we introduce with the topic of HCBS and the institutional bias, whereby while Medicaid pays for long-term support services, because of the way that Medicaid was enacted, those services are mandatory benefits for only when delivered via institutions. So even though people with disabilities do have a legal right to receive care in their community, if that's their preference and suits their and that is a way they can receive services, that nevertheless is essentially an unfunded mandate. It is a right without any financial obligation to fulfill it. And while we have, taken steps to provide greater access to HCBS and transition away from institutional settings, at present, that is still an underfunded. HCBS is still underfunded, and there are significant wait lists in many states. So that does drive a number of disparities between access to care service. The other thing we do talk about is at length is HCBS workers and pay disparities. This is a place where a pretty significant history of specific racism is present. Early labor protections essentially excluded domestic workers, and I believe farm workers were the other category from a lot of early labor laws, and the direct support workers being in that class of domestic work have been historically under protected and underpaid, and that has had a long-lasting impact on the stability and on the stability of this work. So and then the last thing we talk about is the data gaps that exist in HCBS demographics. There is very little data on non-elderly long-term support recipients, and that because while everyone is more likely to become disabled as they age, people of color, that is a much quicker process and it happens much younger, and as a result, there are more non-elderly disabled people as a portion of the population than of color than there are for white people. So that demographic gap actually means that there's a gap of knowledge around the experience of people of color with disabilities. So our policy suggestions there are to improve HCBS data collection, including racial and ethnic demographic data, improving HCBS and eliminating wait lists, and improving the pay and working conditions for HCBS workers. Again, we feel that impacts not only the people who are recipient of direct support work, but also because a lot of support workers are also supporting family members or friends unpaid. Better pay and support for HCBS workers also has an impact on disabled people of color who may not be captured by the support system. So for criminal legal system, we talk about the impact, how policing impacts race and disability, the fact that a large number, I think 30 to 50% of use of force incidents are the best statistics I was able to find, include people with disabilities, and that the way we also talk a bit about police presence in schools and how that is also occurs disproportionately in schools that are predominantly of color. So we also talk about it from the other end, that looking at the incarcerated populations, and I believe the best number I had there was 30% of people in prison have disabilities, and that is about triple the national population, the national proportion. So people with disabilities are also significantly overrepresented in prison, and that's just identified disabilities, which is probably an underestimate. So our suggestions regarding policing, we suggest alternatives to policing, especially where it involves crisis response for mental health and social service issues. We as well as ensuring as much as possible that police presence in schools is limited. Our takeaway from a lot of this data was that any place police are present, there is a risk of police violence and arrest. That is essentially the job of police. And that does mean that anything we can do to limit contact where it is not necessary is something that will ensure the safety and independence of people with disabilities. We also talk about holding police responsible for misconduct, violations of civil rights, and violence. We think that it does need to be a systemic, system-wide, institution-wide process, rather than one that focuses on training. Training still requires a degree of enforcement and accountability to have an impact. We also talk about alternatives to prison where appropriate, and we do want to be clear here that we don't mean forced treatment, that is still a carceral and punitive process that turns access to supports into a punishment, which is not the system that we really want either. And then another thing that we focus on is ensuring that there are adequate supports for disabled people who are involved in the justice system at every stage. That means adequate support in diagnosis for people who are pre-trial, but it also does mean ensuring that people who are returning have access to services and continuity of services when they come back, ensuring that people have access to Medicaid and HCBS when they return if they have a disability, ensuring that people have access to vocational rehabilitation in prison as well. And for housing, we talk again about the impact that racism has had on housing communities, the history of things like redlining and the impact that's had on community investment. We talk about housing quality, the importance of having safe, accessible, and healthy homes, which is also critical because it impacts not only your risk of additional disability or increased disability, but also it impacts housing stability as well. And then we do talk about housing stability. Again, I think the number is like at least 25% of people by point in time counts are disabled, and housing insecurity is very high among people with disabilities. So we also focus on that as well. And so our policy suggestions there are to increase the affordable housing stock, increase the availability of affordable housing systems like housing choice vouchers, mainstream and Section 811 vouchers, improving benefits again to ensure that people, if they have a discrepancy in their benefits, don't lose access to their housing, to basically ensure that people have some stability in housing by making it easier to retain housing even if there are discrepancies there, and to ensure that they're able to save. So if they do need to relocate or have a difficult month, they are still able to retain their housing. And we talk about improving fair housing laws. Again, the majority of fair housing complaints are concerned disability, so that is another place where we really need to see a significant focus. And then we talk about improving eviction protection for renters. Most people with disabilities rent. And again, housing insecurity is very high among people with disabilities, and they frequently have very high eviction risk, and that eviction has a very significant adverse impact on outcomes. So, and then finally, healthcare. For healthcare, we talk about the impact of race and disability on long-term health, and here we focus a lot on social and economic determinants, and the fact that both race and disability have a significant impact on risk of chronic health conditions, and that can create a real feedback process of chronic health conditions, especially if untreated or undertreated, can lead to additional disability. We also talk about, from there we talk about healthcare access, which also can be linked to community disinvestment frequently. And then we talk about discrimination in healthcare. This is one of the few places where we focus on per se bias. And it's also one of the few places where we actually suggest representational diversity as a means to improvement, as I'll mention now, that when we talk about policy suggestions, one thing that we do focus on is the importance of representation of people of color and people with disabilities in the medical profession, especially among medical educators and medical policy decision makers. We have seen that there's often bias against people with disabilities in things like crisis standards of care and transplant policies and a number of other and other places like that. We strongly think we do think it's important to see people with the relevant life experiences serving in places that set policy, that review ethics, and that educate physicians to ensure that people with those experiences are actually present and able to address some of those sources of bias. We also do talk about, again, improving social determinants, addressing disparities health disparities tied to race and place, as well as improving healthcare access for medically underserved communities, including, again, designating people with disabilities a medically underserved community. We also discuss improving access and affordability for healthcare services generally. One thing that is particularly relevant here is we know that, in places that have still not expanded Medicaid through the ACA, that is an impact that is predominantly felt by people of color who are disproportionately in that gap population. So people of color are disproportionately impacted by non-expansion, and that does mean that disabled people of color among people with disabilities are more likely to be uninsured. So that is a review of the toolkit. I would be happy to take any questions or that anyone in the audience may have, but thank you for having me today.
Thank you so much, Greg. You are such a wealth of information when it comes to policy, and you covered so many topics, ranging from lack of policy to lack of data, need for additional funding. And one thing I want to hear more about from you is what we should be focusing on right now. So when we think about policy, we often think about these windows of opportunity of things that are coming up in legislation or policy initiatives that have been introduced. And so I wonder if there are any areas that come to mind for you of things you think we should be focusing on with policy advocacy in regard to these topics.
So I can talk a bit about some of the work that I'm doing at ASAN right now. A lot of our focus right now is on home and community-based services and ensuring that there is broader access to them. There are a couple things happening there right now. There is currently legislation that is still pending in Congress that we are heavily invested in advocating around to improve funding for home community-based services through the reconciliation package. So that's one thing. Again, this is a place where additional funding is definitely needed. And another piece of that is related to why we do want to see more funding for home and community-based services is that states are transitioning out from predominantly institutional provision of HCBS to ensuring that people are actually in their community and receiving services in a community-based setting. So every state is planned to have a transition plan and go live next year, essentially. And we really encourage on a state level for people to get involved in that process, ensure that states are actually working towards that there's accountability where they are maybe falling short. We recognize that with the pandemic and there is a provider shortage that is related to the underpayment of support workers. So we want to ensure that where states are falling short, that there's accountability and transparency about how they're moving towards that. So I think those are two things that I would highlight on home community-based services in particular. And then beyond that, we're doing other advocacy. A lot of our housing advocacy is also, again, on ensuring that we're getting as much money for affordable housing as possible, and that's definitely related to the current federal budget and as well. So
we've focused a lot too on talking about home and community-based services wait lists. So I'm sure that that is one area that's in your policy advocacy suggestions is end the wait list. So, and that's something everybody can read more about on Twitter or online. So we talked about housing, and then in thinking about health and health disparities, I wonder if you have any specific suggestions that you could make for service providers about things that they could focus on to improve health disparities in their individual healthcare setting.
So one thing that, again, so I think, yeah, one thing that we mentioned in the toolkit is the importance of social determinants of health. And I think one thing that we encourage providers in individual settings to do is think about the health context that people are coming from, other sources of instability in their lives that may be catalysts for improvement of health outcomes. Again, we know that housing instability has a very significant impact on people's health. We know that low quality housing has an impact on people's health. That employment and employment outcomes, so I think that is one thing. I think every provider should definitely keep an eye on social determinants of health in other ways that someone's life context may not only be contributing to their health conditions, but also may provide additional barriers to accessing care. And I think the other thing related to that is one thing we do talk about that I think is worth highlighting is, again, we do talk about in the context of the healthcare toolkit is the existence of health discrimination in healthcare settings against people of color, people with disabilities, and especially disabled people of color, that a lot of people of color are not necessarily, there are often biases against disabled people of color advocating for themselves in healthcare settings. They may not be believed, they may be perceived as drug seeking or other non-compliant when they are advocating for themselves and expressing what their concerns are. And I think we really all need to be very attentive to that and ensuring that we are providing the best care we can to what people who are advocating say they need. And that also includes, there are stories of people with disabilities who have language access needs and have their assistive technology taken away from them, or aren't provided or don't have access to their support workers who may be an important part of ensuring that they are able to advocate. So I would say those are all things in this context that are really important that I would highlight.
Yeah, and what I hear you saying too is just being aware is such a critical baseline action that everyone can take. Being aware of health disparities, asking questions, and screening for basic needs to make sure that people's basic human housing are met, and to understand better what challenges people are facing when they come into a healthcare setting. So I appreciate that. We have a question from the audience. What are your thoughts on how support services are often reserved for people that either fall into the category of intellectual disability or severe mental illness? So I assume this person is also getting at disparities in eligibility criteria that sometimes disadvantage people who are on the autism spectrum and may not have intellectual disability or mental illness.
Yeah, I think there are a few things. So my understanding is every state is a bit different here in terms of what their criteria are. This is something where I did some very early advocacy on DC's criteria, which did require a formal ID diagnosis that was tied specifically to IQ. And we definitely discourage that. We think that it's really important to focus on what people's functional support needs are. And that even within that, there is often a lot of criteria focus entirely on ADLs, activities of daily living, which are usually things like feeding and clothing yourself, often have a bit of a bias towards, honestly, physical disabilities as well. And I think we also talk about IADLs, which are things like navigating to the store, shopping for yourself, cooking for yourself. Those are a little more, they're still things that people need help with in order to get by. And they are still places where people need support, but frankly, not every support system does offer those as robustly as we would want. And I think that does mean that a lot of people who may not have intellectual disability, or in some cases, some people who do may just be excluded from services that they really do need to get by. And that is something where we really strongly encourage a much more robust criteria that include more people with disabilities actually being able to get the services they need to live independently. So.
And really highlights issues of intersectionality, I think, about being able to qualify for services and then maybe having difficulty advocating for yourself. That's issues that people would face based on color. I have another question from the audience. This person says, I've been interested in mobile crisis units or crisis response teams that are being used to help alleviate certain situations that typically police could be involved in, but can result in a really bad interaction. But typically they only serve individuals with drug use problems or anything drug use related. How could you draw the connection between drug use and people with developmental disabilities or any type of mental health concerns? So I think they're asking, are mobile crisis units or something similar applicable when addressing policing issues related to people of color and disability?
So this is something we're heavily engaged in. There are proposals. So there is a upcoming plan for a national 988 number, which is going to connect to, it basically does connect to the National Suicide Prevention Line, but the idea is that it will also interface with these mobile crisis teams. Now, I think one thing that is of concern to us and that we really are advocating around is ensuring that a lot of these plans are a bit agnostic as in terms of the extent to which the police are involved, and whether there are a number of models out there. There's co-response, there is the idea of police being cross-trained. Those are things that we are much more leery of, because we do think anytime a police officer is present, especially armed police, which any officer on duty typically is, there is a risk of both police violence, but also arrest. And honestly, even in a co-response situation, it may be a situation where somebody's told that they have a choice to go with the police or go with the crisis unit, and that is still coercive. So I think we are heartened to see that this is being propagated on a national level, but we do have some very particular concerns about how it doesn't interface with people with mental illnesses, people with developmental disabilities, and ensuring that it's being done in a way that is safe and respectful and ensures that we are able to still have our rights within that system. So I think there is definitely movement on that to ensure that it is not only for people experiencing SUD, but we just do have to, I think this is another place where there is a lot of advocacy opportunity just to ensure that it is being done in a way that actually does, that does ensure our safety. So.
Yeah, and it highlights learning from innovations from other populations. So that's very exciting. I know we're jumping around a little bit on our topics here, but I want to go back to housing for a minute. Are there specific trainings that you would recommend to support staff to understand more about autism and how to effectively support autistic adults in supportive housing settings, or even for families to trainings they could take if they're caring for an adult autistic person at home. So I think housing, gosh, housing is just such a huge topic, ranging from people having a place to live, but then thinking more about maybe home and community-based services that support people to live at home. Any recommendations specific to HCBS along those lines?
I know that we have, I know that ASAN does have some resources for supporting for families looking for more information about autism to support autistic individuals. I am struggling to think of something specific right now, and I'll confess. But
one thing we've been talking about and trying to learn more about are supports for family caregivers. Sometimes there are paid supports for people to offset costs, things like that, in addition to training. So that might be something people could read a little bit more about as well.
I do know that there are some organizations that do work more closely with support staff. And Core probably do have something. Yeah.
Okay. Someone would like to know, how can we ensure that mobile crisis teams do not perpetuate existing racial disparities with the police? For instance, how to ensure that people of color have the same access to alternative responses to policing?
That is a really good question. I think so. I think some of this does have to be policy level, but it gets very challenging because a lot of the policies that we're seeing coming out on the federal level are very leave it up to the local community to identify the process they're using. And I think that leaves room for heavily policed communities to continue to be heavily policed. So I think it is really important to establish a framework where we actually are treating seriously the issue of over policing and ensuring that police, where police don't have to be there, that it is a non-police response. I think that's for us the main takeaway there. I think there are a number of different models. I think the Cahoots model is one that I've seen that really is a community-based approach that really does focus on community supports that are outside of the police system. And I think that is really what I would encourage more than anything for communities to look at, just to ensure that the role of police is not, that is limited.
Can you spell the name of that model in case people want to look that up?
Oh, so I think Caitlin linked it in the chat, but
Great.
It's all caps CAHOOTS, and yeah, a number of locals have used that, and that is one model that I'm aware of. I know that there's a couple others, but at the same time, yes, we also know that some locals are looking more at co-response or cross-trained police or limited hours, where outside of those hours it gets routed to the 911 system and police. So I think the other piece because of that is that it's important to make sure this is fully funded and 24/7, and that it's not something where if you call after 7 the police respond instead. So I think that's another place where there's some serious concern.
Okay. And I want to point out, going back to housing again, that someone is saying some states, long-term support services and HCBS allow family members and even sometimes parents of minors to be paid, but that this could possibly, and that framework could possibly disincentivize against full independent living if funding is going to parents instead of to individuals on the spectrum. And so just want to point that out. But along those lines, thinking still about HCBS, someone is asking, how do you think states are doing to prepare for the 2023 implementation of the HCBS settings? And you might want to, if you can, just explain in a couple sentences what the settings rule is.
Okay. Yeah, I can definitely do that. So the settings rule. As I mentioned during the presentation, there was a court case about a decade ago now that declared that under the ADA, people have a right to receive services in their community if that is suitable to them and they want it. Following that, the federal government had to go through a rulemaking process to basically support that, and the Center of Medicare and Medicaid Services released a rule called the HCBS settings rule, which says that HCBS funding will settings have to meet a certain number of criteria to be considered community-based, and communities that don't allow people certain degrees of independence, community integration, self-directed care, those that they are not community-based settings. So as part of this, the states have to release implementation plans explaining how they are ensuring that that they're meeting the settings rule, that people are able to live independently and self-directed in their community. States, that rule has been delayed for a number of reasons since then. So the current implementation deadline is March of 2023. It was the last time it was delayed was because of the COVID-19 pandemic, which did put a lot of states and a lot of settings under a lot of unique constraints that made it very hard to expect compliance by this year, which was the original deadline. Not the original, but the most recent deadline before that. So states, I think a lot has gone on, and part of it is that with the delays, it hasn't been a lot of states' top priorities, unfortunately. But also there are other issues, like there is an ongoing shortage of providers because providers are dramatically underpaid, which has meant that during the pandemic, that provider shortage has gotten more severe. That being at the same time, other staffing issues have also meant that a lot of settings that might have been qualified under the settings rule have consolidated and become kind of a bit more institutional, which is very concerning to us. And what that has basically meant is most states are not anymore ready for that implementation deadline than they were a year ago. And I think right now about half of states have a finalized transition plan. So it's not where we want to be. And I think even CMS is kind of aware of that, because they are providing some flexibility to states in meeting that in certain places where the staffing issues are going to impact that. And that means that states are going to be basically releasing new information about where they're going to fall short and what they're going to be doing to get to where they need to be. And I think it's really important that we be engaged in that process and and give feedback to states where there are things that they need to be doing, and things where their plan, if we think their plan doesn't meet our expectations or needs, that we say so. And I think I really encourage everyone to be involved in that process, because that is going to be a very critical part of how this goes forward. And it is a real challenge. And again, I don't want to disparage or make light of the real struggles that a lot of these settings are experiencing, because the staffing issue is real. And it's not really the fault of settings that support workers are underpaid at the end of it. And
I'm sure we could spend a whole nother entire webinar talking about lessons that we've learned from COVID in terms of disparities been highlighted, but also positive innovations that have come out of it too. So such a rich topic, and put into the chat a link to look to read more about the age settings rule. So I'm going to turn over to Kyle to wrap up, and thank you so much, Greg, just for all your expertise that you shared with us today.
Thank you for having me.
So everyone, thank you so much for joining us and sharing time with us, time and space. Just a quick reminder, stay in touch with us at Impact Policy on Twitter. Follow us on LinkedIn, Policy Impact Project there. Check out our website. That is where all of our webinars will be housed at policyimpactproject.org. And email us at policyimpact@drexel.edu. And most likely, there should be a pop-up at the end of this webinar. But if you have a moment, you can use this QR code to take a brief survey. Just once again, let us know how we are doing. Everyone, thank you again. Thank you for sharing space, sharing time. Let us talk about this topic. And Greg, thank you so much for providing us with information, recommendations, and because of the accessibility of the toolkit, no doubt this will have a far reach. Thank you, everyone, and have a wonderful day.